kind introduction. I'd like to thank the organizers for having me. It's an honor to be invited and a pleasure to present. I cannot aspire to deliver a keynote which covers the breadth and the depth of the topics that you've been discussing. So my take at it would be that I'll share with you an example where big data is making a difference in the way we innovate, we create solutions, we validate the solutions in the context of acute patient care where it has a huge potential to change the outcome, to change the way patients are treated and cured. I'm very well aware that I'm the first speaker after lunch, so your energy level may be as aigu and peaked as the Mont Blanc, which is why, to introduce quickly, même si vous connaissez la société Philips et nos logiciels et nos solutions médicales, la filière recherche vous a peut-être échappé jusqu'à présent. Et donc, fondée il y a une centaine d'années, nous sommes actuellement 1500 scientifiques chercheurs à travers le monde et installés en France depuis les années 50, actuellement juste au sud-ouest de Paris. On the other side, and I'm going back to English, no worries there. I thought it would get me a laughter or two. We've been here for 70 years, 50 years of which in the same place in New York, and just last year we moved my lab with about 200 people, lock, stock and barrel, here to Cambridge, a mile just behind me. So an open invitation to any one of you if you'd like to visit us, if you'd like to do an exchange. We're absolutely passionate about what we do, and we'd like to share some of that passion with scientifics, with business developers, with all of you. I picked an example out of the continuum of care that we address in healthcare at the intersection of diagnosis and treatment. Because, as was alluded to earlier already, the amount of data that we have at our fingertips is just enormous. We're managing more than 20 petabytes of data currently in imaging data for our customers, but that's not the example that I wanted to share with you. What I did want to share is in acute care, we have 275 million patients every year who, in some form or other, are connected to our monitoring equipment where their vital signs are flowing off into central databases. And that's just a wealth of information that is too valuable to just simply sit there and ignore. So in that space, what we do have is that data trove of information, and there was a reference earlier this morning to data. Well, information is what we're after. You start with the data, and without curation and without compilation, annotation, ground truth, it's worth very little. On the other hand, if you had tens of thousands of patients of data with their vital parameters off of an ICU, with the medical record that goes with it, combining those two, you don't need to wait for the patient to deteriorate on the ICU. You can do something about it. We've started that, as I'll show you in a moment, more than 14, 15 years ago, in collaboration with Philips, with the research arm, with MIT, with Beth Israel Deaconess Medical Center here in Boston. Because the case in point is you can do something about it. You don't need to wait till something happens, but you can leverage the information that is in that trove of data. In this particular case in point that I was going to share, it's hemodynamic instability indicator predicting something better than just measuring the blood pressure and seeing when that goes out of bounds. The approach is compile the database, share it with the research community, and I'll be explaining in a moment why that is so important to us. So keeping it close to us is of no advantage whatsoever to the company. If we want to make an impact with it, we need to change the way we work, and we did that starting 15 years ago. Combine it with machine learning, combine it with the appropriate physiological modeling, the understanding, the things that a clinician would also bring to weigh in on the question when he sees the vital parameters in the ICU. Develop accurate predictions with the ambition to be accurate for each individual patient. So making a change for those 275 million patients that are on our monitors, but accurate for that individual patient and not just on average. Optimize it and validate it retrospectively versus the database that we've created and curated. And then, yes, there's still something left, and I'll share that with you towards the end. We still need to validate it in the clinical environment because there are a few ethical questions, there are a few workflow questions related to that. And then the outlook is how we extend it. So we started in the years 2001 to 2008 with grants that I'd like to acknowledge from the NIBIB in partnership between academia, clinical excellence center, a tertiary care hospital, and Philips to curate a database with currently more than 40,000 ICU patients. Given that a patient is on an ICU typically for more than a day, unfortunately in many cases much longer, this database amounts to more than 1 million hours of vital parameters and not just blood pressure, all the things that go off of the monitor. So that 1 million of hours there, we need to leverage it. On the other hand, we can't simply use that information. So as part of the partnerships, we removed all of the identifiable healthcare data from it. But we needed to do more because based on the admission to the ICU and the discharge, just having the dates would potentially allow you to identify the patients. So the dates were randomly shifted in addition. That's the curated database. It has the physiological signals, the vital signs, the comprehensive clinical data, so the annotations. We can do something with it. It's available to everybody because, as I was saying earlier, keeping that data to myself, having the scientists create a prediction or algorithm, that's not going to cut it. We want to have all of this curated data available for anybody who is working and knows how to work with this sort of data. So the MIT colleagues are the gatekeepers. They register interested scientific partners to use the data because we hope that somebody's going to come up with a better algorithm than ours so that we can together make more of an impact. If we can show that the data are useful for looking at prediction across different time windows with different aspects, we all stand to benefit and to convince that this sort of additional information is of value in patient care. This may not be legible, definitely not from back there. The intent is to just highlight that it is data from ICUs, different ICUs from a single tertiary hospital that was willing to go through the trouble of annotating it, curating it, and putting it together. It has also external data like the mortality information that you have access to here in this country, combined with user feedback put into a curated database. We went a step further. We have about 10% of the ICU beds in the USA benefiting from a telecare solution where specialists, ICU specialists from far away are looking over the shoulders of the personnel in the ICU. That's hundreds of ICUs, that's millions of patients, 100,000 of which we've again put into the public access so that others can develop their algorithms against it, validate it against it, and sort of challenge us and work together with us in improving patient care there. This data set is even richer. It has vital signs, it has pharmacy, so the meds, it has the lab results, diagnoses, ventilation data, fluids and interventions, severity of illnesses and outcomes all put together, and that's being curated as I speak and being put onto that same public repository, the PhysioNet, that is guarded by the MIT colleagues. What's the aim? What do we want to do with that trove? We've got something in our hands, but it's a bit like the wizard. We don't really know what this could mean for us or for patients. So when we look at the current status, there is a comprehensive monitoring on the ICUs. There is very well-trained staff that are in a tight control loop of looking after these things. They are detecting deterioration the moment that the vital parameters go out of bounds, or in cases of smart alarms, combination of vital parameters flag it. Still, there's an information overload. All of that information going in there. There's alarm fatigues of looking at, do I need to intervene now? Is there something that is potentially materializing? And there's a need for a near real-time decision-making, because the moment that the patient is going out of bounds, there is a scramble to try to get him back into bounds, get him into safe limits again. What do we want to do with it? We want to replace it by early warning indicators. Some of them have been around as scorecards, as charts, as a few other things that are just running in the background, and that would flag earlier on that something's going to happen to this patient, because you ain't the first patient that we've seen on our system with that combination of vital parameters, and we've probably seen a few 100,000 that were very similar, and we know what happened to them 2 hours, 3 hours, 4 hours down the road. To not just be able to flag those patients for additional attention or additional evaluation, but to also start thinking, okay, this patient is going to have that thing, to bring in additional help, to bring in the additional consultation, the consults earlier on. What we did, I showed it at the bottom left, we combined these two databases. The research scientists looked at labeling it, excluding those hospitals where fluids were not charted regularly. We excluded patients that had the flag of do not resuscitate or similar. There was offline data mining. There was retrospective evaluation on the own data sets. And just to say that it isn't as simple as it may seem, the workings behind, I don't want to go into the details, I just want to highlight that the vital parameters have one part of the prediction, the demographics and other information are combined in, the labs data are a component, and the art and the science is in some way of combining them in a fashion which will allow an early risk detector to sort of flag patients which may need additional attention, which may run into problems earlier on without creating additional nuisance alarms. It's a fine line there. If you just used, and I apologize for the acronyms out of a scientific paper, the simple blood pressure measurement itself, and these are ROC curve areas, even if you look at, so where should I point? Probably here. Even if you look at zero lag time, if you look at the current moment, it alone is not a very good predictor, be it invasive or non-invasive blood pressure alone for an event that the patient may be having soon. The further you go back, so if you were trying to aim at 4 hours prediction that something would happen, it gets even worse and worse and worse. Just the vitals are better, but again, how to determine the right point here? The vitals, the demographics, and the lab values together are a rather good curve, and now part of the development work, which then is proprietary, no longer shared, is to try to determine the right moment, the right sensitivity, specificity, and the right prediction amount. So how far ahead of time do you want to alert it? And then to validate it, of course, and this is a retrospective validation on the data set itself, but that, of course, isn't good enough. What we need to do after having validated that, after having chosen an operating point, after having gone for a particular sensitivity and specificity with the one hospital that curated the original data set, with our data set of the remote ICU support, we're still faced with the ethical challenge of, if we raise that additional flag and alarm, will it be used as an additional caution measure? Will it be used in a way that the patient gets additional care in those moments? Or will it lead to a misconception potentially that somebody could think, well, that alarm didn't go off, so the patient's not going to have trouble 4 hours down the road. Indeed, it was deliberately designed to have a low false alarm rate. But that means that it will not raise a flag for every patient that's going to have an event. It's a difficult trade-off there, and that is to be seen in the clinical workflow. What changes will appear? Will it be seen as a useful addition? And what we're essentially trying to do here is to say you get an additional warning flag in some cases where we are sure that something's going to happen because we've seen so many patients go down that road before. Secondary endpoints, like in any clinical study, there's a few of them, but the main endpoint is the time to the appropriate intervention and the time to the antibiotics in cases where that is required. Those are the goals that the clinicians have set, and now the bigger challenge is this goes from not having these alarms, not having these leading alarms, to the first instantiation that we have. But once the alarm is changing the way that the clinicians are reacting, how are we going to prove the next generation of slightly better tools? We can run them retrospectively, and again, there's part of the value of doing this in an open fashion instead of in a closed fashion, because we can all work on that compiled trove of data. We can all challenge each other on that retrospective data so that we limit the number of prospective trials that we need to do going forward, because we've already, on hundreds of thousands of hours or even millions of hours of patient data, been able to determine the operating point to the best of our judgment before going in. It's sort of like in the dark, you've got a bit of GPS navigation of where you need to go. Well, that GPS may not be accurate, the maps may be out of date, you still need to validate it, but it gives you a good head start. That's what we were busy with, and currently, as part of our collaboration with MIT and its clinical partners, we are looking to extend it into the emergency department that was also mentioned earlier this morning, however, with perhaps a slightly different intent. The intent for us is to say patients that reach the ICU, in about half of the cases, they come in via the emergency department. And in the States, I understand that the median time in the emergency department is 5 hours for these patients. So imagine instead of starting the clock with the vital parameters the moment that a patient is in the ICU, you get an additional backlog of 5 hours to prime the prediction pump. You have all of the interventions that happen in the ED, and you can start that prediction clock the moment that the patient is in the ICU instead of gradually feeding the data pump for a few hours later. The second part of it is to extend it because not all of us, you see my age, from younger children to older adults, not all of the parameters are expected to be totally equal. So we're looking at the different ICUs, extending it with a specific interest into the pediatric space. Because, enfin, ce qui compte, c'est les résultats que vous aurez avec nos innovations. Merci bien.
So thank you. And now we will have